One of the commonest reasons that patients come and see me for a second opinion after ACL surgery is because they still can't fully straighten their knee. In fact, I've seen 2 or 3 patients with exactly that problem this week alone. Sometimes it's just stiffness, sometimes it's related to rehabilitation, and sometimes it's a cyclops lesion. But you know the most surprising thing? Even knee surgeons around the world don't completely agree on the best way to manage it. So let me explain more. Welcome to Sunday Paper Roundup, where I read the paper so you don't have to. Head to toe in Massimo Duty today. Go not market. Bougie. This paper was published in the Journal of Isocos, and the authors surveyed 250 specialist knee surgeons from 25 countries to understand how they prevent, diagnose, and treat cyclops syndrome after ACL reconstruction. Now that sounds impressively international, but it's worth pointing out that almost 2/3 of the respondents came from Germany, Austria, and Switzerland, and the authors acknowledge that themselves. So although this is an international survey, the results probably reflect practice in that part of Europe more than anywhere else. That's important context. Now let's start with the basics. Cyclops syndrome isn't simply a cyclops lesion on an MRI scan. Lots of patients can develop small cyclops lesions after ACL reconstruction. Most never know they're even there, but cyclops syndrome is different. It's when that tissue actually causes a painful loss of full knee extension. And here's something that I think patients often find surprising. MRI studies showed cyclops lesions in around 25 to 47% of knees after ACL reconstruction, yet only around 1 to 10% of patients actually develop symptoms and go on to get what we call cyclops syndrome. So think about that for a moment. Most cyclops lesions never become a clinical problem. I think that's one of the biggest teaching points in this paper. We don't treat MRI scans, we treat patients. And I think that's one of the most important lessons in all of medicine. Not every abnormality you see on a scan needs treatment or intervention. According to the survey, most surgeons considered more than 5 degrees of extension loss to be the key clinical finding. Patients usually presented between 3 and 6 months after surgery. So, what did the surgeons actually agree on? Well, interestingly, quite a lot. Almost everyone agreed that prevention starts before the operation. The 2 most important factors were making sure that the patient had regained full knee extension before surgery, and that's where prehabilitation really comes in, and accurate tibial tunnel positioning. I always say never accept a stiff knee before an ACL reconstruction. And yet, despite that, I still see patients every week who've come to me for an opinion after rush surgery without ever having had enough prehabilitation or having regained full knee extension before. Honestly, I think it's so easily avoided for so many patients, there is no need to rush in. And that's one of the reasons I really wanted to cover this paper. Another area of broad agreement was that most surgeons didn't recommend rushing straight back to theatre. Around 2/3 favoured an initial period of extension-focused rehabilitation, but still, almost 1/3 would proceed directly to arthroscopic excision once their clinical criteria had been met. I actually think that's one of the most interesting findings in the whole paper. Even amongst experienced knee surgeons, there's still meaningful disagreement about exactly when rehabilitation ends and surgery should begin. To me, that tells us the evidence still has gaps. Another reassuring finding was that recurrence after arthroscopic excision was uncommon. Around 2/3 of surgeons estimated the recurrence rate to be less than 1%, and that's reassuring for the patients who genuinely do need surgery. Just as an aside, when my colleague Tim Spalding and I at Cleveland Clinic London are treating loss of extension after ACL reconstruction, you'll often take an RF probe, occasionally a shave with great care to debride any excess tissue back, but also quite aggressive at doing a notchplasty. I tend to use a curette. Tim much prefers a burr. And to create 1 or 2 burrs width space around the ACL to give it space to breathe and move and fully extend. That's a free tidbit. Now, what I particularly liked about this paper wasn't that it gave us all the answers, it didn't, but it showed us something almost as valuable, where experienced surgeons still disagree. There was considerable variation around ACL remnant preservation, exactly when to obtain an MRI, and the timing of surgery. And that's useful because when experts disagree, it usually means that the evidence isn't definitive yet. Now, of course, every study has limitations. This is a level 5 survey study. It tells us what experienced surgeons say they do, but not necessarily what they actually do. There are no patient outcomes, no comparison groups, no randomized trials. So this paper doesn't prove that one management strategy is better than the other. It provides a snapshot of current expert opinion, and that's useful, but it's a very different thing. One thing I do think deserves real credit is that the authors didn't just publish a survey and crack on. They used those findings to propose a practical stepwise management algorithm, recognize extension loss early, start with extension-focused rehabilitation, use MRI when it answers a clinical question, and reserve surgery and arthroscopic excision for patients with persistent symptoms. That feels logical, it's pragmatic, and it's patient-centered, even if it still needs prospective validation. So, does this actually change what we do? If you already have a structured approach to diagnosing and managing cyclops lesions and cyclops syndrome, then probably not. You'll recognize most of the principles in this paper already. But if your approach is more variable, or you don't have a clear pathway, then I think this paper genuinely has something to offer. So what's my verdict? Should we ignore it? Should we be aware of it and keep it in mind when we see patients? Or should we go right ahead and change your practice? Well, for me, I'd go as far as to say go ahead and change your practice if you don't already have a structured approach. Not because this survey proves that one pathway is superior, it doesn't, but because the proposed algorithm is logical, pragmatic, and closely reflects where international expert opinion is converging. If you already manage these patients this way, this paper probably reinforces what you're already doing. If you don't, I think it provides a sensible framework worth adopting until stronger evidence becomes available. As someone who spends a lot of time seeing patients who've struggled to regain full knee extension after ACL surgery, I'd much rather prevent this than remove it. I'll see you next Sunday. I'll keep breaking down the evidence as it lands.